Hello, my name is Mike Plew. I share the same license as Steve as a marriage family therapist, and I'm also an educational psychologist, and I've been working with adults and children with disabilities for some time now. And so today I'd like to talk with you about an overview of crisis and common strategies used to help people who are in crisis. And then we'll talk a little bit about mental illness. So in order to give you kind of a conceptualization about where the people are at that you're meeting with, I'm going to present to you 4 different categories of stress or anxiety or crisis. And that way you'll have an idea about where people are at. So to help you remember, I've called it 4 yucky things that happen in life, or types of yucky things that happen in life. So the first one is stress. We'll go through each of these. The next one would be unpleasant events. Then there's crisis. And then there's something called trauma. These last 2 areas are important because they're separated from the first 2 by this important concept, functioning. And we will come back to this word. It's a very important word when you're working with people because if they're on this side of functioning, if you're an adult, that means you're going to work or whatever your task is in life. You're not having legal trouble. You're not hurting others or hurting yourself. If you're a kid, it means you're able to participate in whatever normal comprehensive campus you're on. At a junior higher, 6 periods a day. You're getting passing grades. You're not in the discipline office. So functioning is a very key piece of information to get as you're meeting with people, because that often tells you how severe their issues are. So let's start with the first one, stress. So stress is, we're all familiar with this, right? Family stress, the stress of being married, having children, the stress of relationships, extended family, of course, our stress with our jobs, and the stress of various life goals, finishing college or getting that certification. We might define everyday stress as the normal and expected tension and worry of daily work life, dealing with people and encountering common challenges and interpersonal conflict. So a couple key things here. First of all is that this happens every day to everybody. And for every one of the 4 areas of yucky things in life or types of crises, I'm going to give you kind of a gauge where they are functioning. So for everyday stress, I'm sure you would guess that they are clearly in the functioning range. No matter what type of stress happens during the workday or at school, they're functioning. They're eating, they're sleeping, they're not hurting themselves or others. The next type of stress or level of stress might be called unpleasant events. Unpleasant events are not everyday events, but they are still common. They're things that most people can share stories about. So unpleasant events might be defined as occasional negative experiences that are experienced by many people. And this also would fall squarely in the functioning range. So these things that happen, fender benders on the freeway, a flat tire, a reassignment at work, these are stressful. These are unpleasant events, but most people continue to function. So now let's step across the functioning line into official crisis. So a crisis is usually in the literature defined as an event that is above and beyond the person's ability to cope with it, whether that's actual or perceived. So we might define a crisis as an infrequent event, perhaps an unpleasant event, that is actually or perceived as very negative and insurmountable. So this could be a tree falling in your backyard and, breaking open the roof in your house and having to deal with that. It could be, a significant car accident. It could be a number of things that happen that you feel like you don't have the resources to cope with. Now, by definition, a crisis would be kind of in this middle area. It does affect functioning temporarily, but most people are able to get back on track. So this is how it would look. Something bad happens. And the research tells us that these are all the people that are affected by something bad, whether it's a severe car accident or an earthquake or a fire or something. Okay, here's what the research tells us, is that most people who are involved in some sort of serious crisis, without any help, get back on track. And so this is what it might look like visually. So when the crisis occurs, there's a dip in functioning, but without any or little help, the person gets back to functioning. However, there is always a small subset of people that are exposed to the exact same event. So let's say the Paradise Fires that happened up north. Now that was actually something a little above a crisis called a critical incident, and in some people's case it might be a trauma, but there's always going to be a small subset of people that their response to the event is a decline in functioning. And of course, the big question in the literature is why that is. What's the difference between the majority of people and the small subset of people? And we'll talk about a possible explanation for that. But one big takeaway from, and these studies have been replicated over and over again, whether it's serious car accidents, a volcano, forest fire, the majority of people, after a dip in functioning, get back to their normal state before the crisis event. There is, though, a kind of subset of crises called a critical incident. So you might work where they have something called CISD training, critical incident stress debriefing, and this is basically when something very serious happens, and most people would consider it to be event where you're going to need help. There's, as you can kind of tell, there's a lot of overlap between these four areas we're talking about, and to some extent it depends on the people involved, and I'll show you exactly how that looks in just a minute. So let's take a serious critical incident like a very severe car accident, where maybe you were hospitalized afterwards, your car was totaled. Okay, so but let's say you were conscious, you were awake, and you saw the wreck, and you were watching them remove other people from cars, etc. Like you hear about these multiple car smash ups on the freeway. So let's say you're sitting in the car and you see all this happening. And so how long can we expect the functioning dip when somebody's been exposed to something significantly stressful like this? The research estimates it's basically within 2 months. So 4 to 6 weeks is the normal time frame when we would expect people who've been exposed to a significant crisis to experience symptoms like trouble sleeping, a change in their appetite, trouble concentrating, etc. The research also talks about people who, remember, most people have what we call a restoration of equilibrium. They get back to normal. And then for some people, mostly people who actually get some sort of strategic help, they're actually better after the crisis. They actually learn from the incident. Usually I would say that if you're working with somebody and they've been exposed to some sort of critical incident, especially a trauma, those are people that may need to consider working with a professional in the long term. They may or may not, actually, because the research we learned, a lot of the research we learned about critical incidents and trauma came after the was it 1984, the San Ysidro McDonald's massacre. I believe the perpetrator was James Hubert, but he shot a number of people, babies too, and it was a terrible, terrible incident. So we studied a lot of the people who lived after that, and one of the things that we found was that not everybody needs help. Depending on their family situation, etc. So that always becomes kind of an issue too. All right, let's go to the last one. So we've done stress, unpleasant events, and this is all kind of in the realm of normalcy. And by the way, in the world of medicine and certainly mental health, normal means functioning. So sometimes when I've used that word, I'll hear people say things like, "Well, what's normal?" and everything's relative. But if we use functioning as the litmus test, that's pretty clear, right? So If you're functioning, if something happens and you're functioning, then, good luck to you. If something's happening and you're not functioning, then perhaps you need help. So let's talk about the last one, trauma. This is important because I think today this word has been watered down. And so I wanted to show you what the American Medical Association, the American Psychological Association, and the American Psychiatric Association defines as trauma. I don't know if it's because of reality shows. Humans have always had a penchant for drama. And if there's no drama, sometimes we like to generate it. But you'll hear people say things like, I've been through so much, and when my boss yelled at me, it was traumatic. But I just want you to know what the official definition is, because it's important to use the right words in a professional setting, especially if there's functioning as an issue. So there's 3 types of trauma as defined by the American Standard for Mental and Emotional Issues, which is called the DSM. It's currently in its 5th edition. So there's 3 types of trauma. One is the one that I think makes the most sense. If you're exposed to an event where you thought you were going to die, or you saw other people die, then that would qualify as trauma. So let's say you're pinned underneath a car after a traffic accident, and another car's on fire and you can't get out from under your car and you think you're going to burn to death. Okay, that's trauma. War is trauma most of the time. Another type of trauma would be serious bodily injury, loss of a limb, disfigurement, injury that is very, very serious. And then sexual violence. Now note that this is not abuse. This is sexual violence. So this is, a violent, aggressive episode where, you feared for your life, or you were seriously injured, or there was a weapon used. So this is not, grandpa touched me in the tub. This is a very serious sexual violence, as the name implies. So one thing I think you'll notice if you look at all of the 3 types of trauma here as defined by the DSM, very few of us have actually experienced any of these things. But if you pay attention to TV today, movies, listen to your friends, you're going to hear people say that this happened and it was traumatic. And that's an inappropriate use of the word. And it can lead to some real confusing situations. I guess one of the ones that I see is that, and it's happening where there's, people, of course, looking for benefits because they want to redefine trauma as something lesser than the official definition. So here's some real life examples. This is coming straight out of the DSM. So you can kind of scan down there and see there's war, torture, mugging, severe physical violence, being kidnapped, natural disasters, sex trafficking. So again, most of us have not been exposed to these types of things. And perhaps maybe once in your lifetime, you might. Now, I did want to mention that there is something that you'll see that is talked about. There's a subsection of the therapist community that I call trauma therapists. And they're the ones, unfortunately, that are redefining or watering down the word trauma. And so they'll use something like, okay, to give you an idea, there's a disorder called PTSD. If you've seen the movie The Hurt Locker, that's a good portrayal of it. Basically it's associated with usually war situations, and you have 4 categories of effects after it, even though you're out of that situation: panicky, being hypervigilant, sleep and appetite problems, etc. Well, so I've been in the field, working in the field of psychology since 91. And I'd be hard pressed to actually think of, even 5 cases of PTSD that I've personally encountered. Now, if I worked at the VA, that would be different. I would probably encounter more there. But, PTSD is pretty rare. But what is not rare is people who say they have PTSD. And in the job, my main job, my full-time job, I'm basically assessing students to see why they're having trouble in school and see if it's a disability or not. And I've had a number of cases where people will say, I have PTSD. So I'll ask them what the trauma is. And of course, in my mind, I'm thinking, was it, severe? Was it sexual violence? Was it perceived or real death? And it never is. It's always like I've had people even say that because a teacher yelled at them in front of other kids, that was traumatic. So one time I had someone, I was talking about this because, people want to hold on to this, again, for a number of reasons. And so one time I had somebody say, well, then what do you want us to call it? Well, I would call it what it is. That was a bad event. That was very stressful. That wasn't pleasant. I didn't like it. I felt humiliated, whatever the case may be, but just don't call it trauma. Because in a sense, it's kind of insulting to people who've actually experienced trauma. So what are the normal short-term effects of trauma? So if you and I were, plunged into some sort of civil war and there was bombs going around in the city where we lived and people and bodies on the street, then we would expect in the time after we left that traumatic event, we would expect us to have a heightened sense of fear, anxiety, shock, sadness, disorientation, sleep and appetite changes, poor concentration, any symptom list. This is not, everyone's not going to have all of these. Despair, grief, hopelessness. This is a pretty common one if you stop and think about it. After something bad happens, even something that's not traumatic, like say a funeral of a relative, people often want to find fault. They feel overwhelmed and very upset, and they want somebody to pay. Human nature is not grace, that's for sure. And then some people have false guilt. They have a sense about, why did I survive? Why didn't I help that person? Maybe I could have saved them. People who are, like say in the water when someone else is fatally attacked by a shark will often feel like, why were they attacked and not me? Why am I alive and not them? So sometimes that's an issue that happens as well. So here's some common research-based crisis intervention strategies. Some of them are kind of common sense, depending on if the person is in the moment, coming on, you're talking with somebody who's just coming out of some sort of crisis, making sure that they're in a place where they feel comfortable. If you've ever had that experience of having been in a very stressful situation and somebody's talking to you, you're not always hearing what they're saying. And so sometimes taking the time to ask yourself, asking the person, is this a good place to talk? Should we go somewhere else? Would you feel more comfortable here? Don't forget to, offer physical comforts. Do you need to go water? Can I get you a snack? Do you need a blanket? Again, I'm sure you've seen pictures of war and kids, and they have a look on their face like they don't even know where they're at. And so sometimes you just kind of helping them get what they need, even if they wouldn't ask for it themselves, they kind of maybe are in a state of shock, can be helpful. Now that you have a beginning understanding of the 4 different types of stress levels or crises, then you, in your head, you can think, okay, which category would this particular event usually fall under? And then you also kind of have an idea about, for severe types of crises or trauma, you have a beginning idea about what are some of the symptoms that might happen afterwards. And so you can help the person kind of normalize what's happening to them. And just like Steve mentioned in an earlier session, it's hard to do because we want to help, and we feel like when people say something, we feel like we have to offer something to them immediately. But I would just encourage you, if you're born again, then, do your best and let God work in the situation. You're not responsible for fixing people. And so it's important that you normalize what's happening to somebody genuinely. There was a study in Italy. A volcano went off near these rural areas, villages, and a number of children were affected. And so they basically intervened and they did the study to find out, what helped. And one of the things that they were surprised at is simply taking a group of children and educating them about what happened. Okay, the volcano went off. This is a traumatic event. Most people do not see people dying. Most people do not have an event in their life where they think they're going to die like that. It was sudden. It was, overwhelming. Visually, it was overwhelming. Your home's gone. Your village is not there anymore. Simply educating the children about that reduced their anxiety ratings. And so sometimes you just kind of helping a person in the moment, kind of feeding the back to them, well, it makes sense to me that you would feel that way based on the fact that you were trapped under a car or whatever happened. And then practical things, I keep, almost all of us have a smartphone, I'm assuming. And so you might want to keep a calming playlist, a meditation playlist, whatever you want to call it. But I have, if you go on iTunes or whatever you get your music, you can just, type in relaxation or something. And I've, over the years, collected this, looked and found albums or songs that I felt like are helpful. And I might ask the person, sometimes this helps people. Do you want to try this? And then a close cousin of that is there are a number of relaxation apps on your phone that you can use, like Calm. I think one's called Relaxation Tunes. Headspace, I think, is another one. But the benefit of these is that they have built-in like relaxation exercises that you can do, like, say, for instance, breathing exercises, which I'm not very good at leading people in. I do them myself. Actually, part of my every morning, the quiet time I have with God, I actually now have kind of a meditation time I do in my daily time with God. But leading somebody through that, I rely on these pre-recordings. You can also go to the UCLA meditation site. I forget what it's called. Mark, I think, MARC. And they have a webpage full of these pre-recorded relaxation techniques. In more severe cases, there is something called grounding. I doubt you'll ever get to this, but just in case, I thought I'd let you know. So grounding is a technique where if somebody is really, you can tell that they're having trouble even participating in the conversation, they're really not there with you. You can invite them, right? You always got to remember, you got to invite people and ask them if they would be okay with this, right? We don't want to do anything more to heighten their anxiety. And so you would just say something like, if somebody felt like when you were talking to them, they kind of weren't even there, like they were kind of dazed, you might suggest that, you seem kind of out of it right now, which is totally understandable based on what you've been through. There's something that sometimes helps people. Do you want to try it with me? And so you can just kind of walk them through it. And basically what this is you're using touch or sensation to kind of ground them into, the room that you're in. Now, this is not if you look up on the internet, there's a kind of metaphysical grounding that has to do with Mother Earth's nature. That is not what we're talking about. We're just talking about orienting the mind or the consciousness to the room they're in. There is something that can happen for people who are exposed to severe trauma, something called a fugue state. And basically they're conscious and walking around. They may even talk to you, but they are not aware of what's happening. And so grounding can sometimes, so for example, the most common grounding technique is, of course, to take off your socks and your shoes and rub your feet on the carpet. And you just encourage the person to focus on the feeling of their feet on the carpet. You could do this with less intrusively, I guess, with something in your hand, some sort of object they could hold that would be soothing. Also, in rare cases, when there's kind of like they're out of it, you can do something called orientation. This is basically where you're asking them questions, simple questions that anybody could answer. And usually I preface this by saying, I'm going to ask you some questions that sound silly, but you seem like you're having trouble kind of being here, and I just want to make sure you're okay. So the questions are, who are you? Where are we at right now? Without looking at a clock, approximately what time of the day is it? And the last one is, why are we meeting together? And so if you ever looked on like a hospital discharge, or sometimes you'll see an O times 4, and that's what that means, oriented times 4. And the last thing is, this is like, not the last thing, but last practical thing. It's like coloring for adults. They're called mandalas. I mean, I don't really know why they're called that, but instead of handing a coloring book to an adult and saying, hey, this will help you relax, they probably feel funny. These are very intricate and complex designs, and essentially you're just coloring. And I think part of what's happening here, the reason why this helps people with anxiety, is because it distracts the mind. I mean, one of the hallmarks of anxiety is you get in cul-de-sac thinking. You just go round and round and round about an issue, and of course it never leads to functioning. In fact, it leads to more dysfunction. And so distracting techniques, they're actually used by people who run marathons, right? Chewing gum, listening to music. It's taking your mind off the thing that is unpleasant. And then lastly, I would say, if you're meeting with somebody in crisis, then you should be thinking, and this applies to actually anybody you meet with, is there any long-term considerations here? So, I want to be helpful to this person in the moment. I can pray with them, I can follow up with them, etc. But is there something about this person, what this person is struggling with, that looks like they're going to need long-term help? And that's always something important to keep in mind.
On Halloween of 2003, I was surfing with my friend and her brother and dad, and then I lost my arm to a shark. A shark just came and bit it off, and I don't know, I lost about 60% of my blood, and it was just a miracle that I survived and made it to the hospital, and I'm still here today and just stoked to be alive and doing what I'm doing.
So I don't know if you've seen she has a movie at least, well, a movie is made about her, and then I think she might even have a documentary, but that was, I think, Bethany Hamilton. And the reason why I wanted to show you that is because, I mean, think about it. That's a traumatic event, right? And that's definitely an event where you could have died. A giant man-eating fish bites off your arm. Now, nobody would fault Bethany if she never got in the water again, right? But not only did she get back on the water, but she continued her pro surfing career with one arm. And so you got to ask yourself, what is the difference between people who might experience the same trauma and never get back in the water and Bethany Hamilton? And so you remember our graph that we looked at, right? Most people recover from a trauma, but there's a small subset of people that without help will continue to have functioning problems. So here's the general framework. The two factors that they think about when they think about what separates people who recover from an event, and like Bethany Hamilton, and people who don't, would be the actual crisis variables themselves. So there's a bunch of things about that. The unexpected nature of the event, how long it lasted, the intensity of the event, how close the person was to the epicenter, whatever that was. So all of those things are important, and they can have a bearing. I mean, if you and I were locked in a closet for a month, we probably have problems, right? So how severe the crisis is, and then individual risk factors. So the combination of the two of these will determine whether the person after an event is in the functioning group or whether the person is in the not functioning group. So individual risk factors would be the support system that the person has, prior exposure to significantly stressful events. If you live in a war-torn country and you're just kind of habitually exposed to death, and that might predispose you to not doing so well after the sixth time your life's been threatened. And another issue that related to individual risk factors would be genetic predispositions. And this is in the research about outcomes after a crisis or a traumatic event, this really has become an important finding that's been replicated over and over again. And that is that the person's genetic makeup is important. When they do toddler studies, they'll take, 2-year-olds, and sometimes they'll put them in rooms. They'll have like a daycare situation. They'll have the moms bring the kid. They're all single kids usually, or only childs. And the mom will bring them to the daycare, and then they're filming everything. and they will film, what does the kid do when the mom leaves? And then what does the kid do while the mom's gone? And then how do the toddlers react when the parent comes back to pick them up? And these studies, they try to eliminate as much variability as possible. So like I said, they're usually the first child or the only child, so there's no other siblings. It's usually intact families. There's a mom and a dad. There's been no history of trauma. So they're trying to, as much as they can, get to the personality of the toddler. And here's what they find is that roughly there's like 3 types of responses. Most kids, they're upset. They might cry. They might ask the teacher about their mom, whatever. And then after a couple minutes, they're playing with the other kids and they're fine. When mom comes back, they're glad to see mom. There's another group of kids that is kind of withdraws and is kind of anxious and seems to, and when mom comes back, just, basically throws themselves on mom, clings to them, never wants to leave again. And then there's a third type where their response is more aggressive and they'll actually punish mom when she gets back. The point about these studies is that, these appear to be things that the kids were just born with, temperaments, so to speak. Okay, so let's remember back when you were in PE and you're running track. And then after everyone, does their first lap, then Johnny's in the back and he's kind of bringing up the rear, which is fine, right? But let's say that Johnny really has trouble doing the laps in PE. And more than that, he complains that he can hardly breathe. Johnny complains that he has tightness in his chest, that he starts wheezing, he starts coughing and hacking. And so what would we say to Johnny? If he was in elementary school, would we say, you need to really, make better choices, you need to work out more? No, we would probably ask about a family history of asthma. Take him to the doctor. And if we found out that he has asthma, what would we know? We would know that there's something wrong with a part of his body, in this case, his lungs. None of us would probably be upset that the doctor labeled him as an asthmatic. Nobody would probably be terribly upset if the doctor said that you're going to probably need treatment for this. So if Johnny wants to breathe normally, probably it's going to be recommended some medical strategies, right? An inhaler. There might be some non-medical strategies, maybe some aerobic exercises or something, or only exercising during a certain time. But the research shows that although these 2 types of strategies are helpful, many conditions that people have, whether they're physical or mental, achieve the highest level of functioning if both medical and non-medical strategies are used. So what's important about this is that we're often at the mercy of the disorder. So think about epilepsy. Epilepsy is a condition, right? It's a problem with the brain, and the person has seizures. It's beyond their choice, but there are environmental things they can do, right? Making sure they keep at a low level of stress, and there's medical interventions from medication all the way up to surgery. But here's the thing, there are people, well, the good news is that if you find the right combination of medical and non-medical interventions, you're probably going to have less seizures. But unfortunately, there are people whose condition is so severe that they have what are sometimes called intractable seizures. They cannot stop seizing. And so that's an important thing to keep in mind because for parents or people who get some sort of disability, especially if it's mental and emotional, we need to apply the same things we know about medical conditions to mental and emotional conditions. But that's difficult to do. So just like with asthma, we said that if you have asthma, there's something wrong with a part of your body, the lungs, right? Well, if you have a mental and emotional condition, what's wrong is your brain. And when things go wrong with your brain, lots of things can happen, but most mental and emotional conditions are related to a part of the brain that doesn't appear to be working right. Like say, for instance, a fair amount of studies, actually a large amount of studies for people who have ADHD have found that the area of the brain that seems to be most involved is called the prefrontal cortex, which is right above your eyes. So the point is here, hey, you're not running, you have trouble, you're wheezing, you're coughing. No one bats an eye when we say, hey, that's asthma. and that means there's something wrong with the lungs and they need treatment. Well, we need to have that same sequence of rational thought when it comes to mental and emotional illness. But of course, that's not the way it usually goes. So 3 important words I want to kind of stress when it comes to mental and emotional conditions. Back to our word functioning. You may be a little shy, right? But that doesn't mean you're autistic. You may be a little kind of like not the happiest person in the world. You're not the life of the party, but that doesn't mean you're depressed. There's lots of diversity, right? But again, if you're not functioning, or there's some aspect of your life that's a problem, then that's when you need to think about it. Unfortunately, my experience is that if humans can get by at all in life, even if that means stumbling through life and having people around them pay significant price, like say for instance, my dad left when I was 5 and he was married 4 times. So he left behind 7 children and 3 families. He died in his 4th marriage, but so my dad might say, "Hey, I'm fine, right? I work, but there was an issue that he had that was affecting his functioning, and maybe he didn't feel like he paid, but the people around him were certainly paying." Also, I want to mention the word label. This is an unfortunate thing that a lot of people get hung up on. So when you go to the mechanic and your car's not running, and he looks under the hood, then he says, "All right, go ahead and give me $500 and we'll get it working." What's the first thing you're going to say? You're going to say, "Wait, I need to know what's wrong first," right? You would never just, let's say you took your kid to the doctor and the doctor looks at your kid and then says, "All right, I'm going to give your kid this shot." You would say, "Wait, hold up. What's the diagnosis first," right? This is the way it always goes. Diagnosis first, then the treatment. Your treatment is only as good as your diagnosis. What I hear some people say, and it's frankly just denial, sometimes it's ignorance, but they'll say, I'll look at a kid's history and I'll say, "Well, all the evidence suggests that the reason your child's just having problems in school is because of something called ADHD." And then somebody will inevitably say, "Well, I don't believe in labels. I don't want to label my kid." Well, you won't have a problem if I labeled your kid a valedictorian or a Mensa member. So we only have problems with labels if we don't like them. But we understand in all other areas of life, our dentist, our doctor, our mechanic, that we need that label or that diagnosis of what's wrong because that determines treatment. And then the last thing about mental and emotional illness I wanted to point out is that there's been 2 national studies about mental and emotional illness, and they look for, what's getting in the way of helping people with mental and emotional illness. And one of the big findings has been stigma. So, unfortunately, there's a lot of misinformation and myths about mental and emotional problems. But remember, back to our first thing we talked about, it's no different than when something goes wrong with your lungs and we call that asthma. When you have a mental emotional condition, it's the same process. You get the diagnosis, you get the treatment, you move towards functioning. But again, when it comes to mental and emotional problems, I think, and maybe it's because it tends to affect the personality of the person more. Maybe that's the reason why we have trouble with it. If I have asthma and I talk with you, I still interact with your personality. It doesn't change because you're having trouble breathing, unless you're in the middle of an asthmatic attack. But if most mental and emotional illness, it does affect, relationships and the way the person interacts with others. And so maybe that is part of the issue. Here's 4, this is a crude oversimplification of mental and emotional conditions, because there's over 250 different types in the DSM, but I think this framework will help you. So basically there's mood disorders, right? There is depression, bipolar, and anxiety disorders. And there's categories under each of those. But sometimes functioning is affected by something's wrong with our mood. I think women understand this intuitively, right? I mean, I've always thought when it comes to men and women should have the least amount of denial when it comes to mental and emotional illness, because they understand that once a month, depending on their cycles, their mood and their functioning is affected by something that goes on in their body. Right? They understand that they lose a certain amount of choice when it comes to how they feel and what they say and do. Well, that's a very small example of what happens with someone who has mental and emotional problems. Then there's thought disorders. The most probably widely known one. And if you go to 7-Eleven or see them, San Bernardino, wherever you're at, many homeless people have schizophrenia. And that is a thought disorder. It's also characterized by hallucinations, seeing things, hearing things, etc. So that's also, there's something called delusional disorder, but something can go wrong with how you're thinking. ADHD is obviously, everyone's heard of that. And then autism. I think those are 4 good beginning frameworks for you to think about mental and emotional illness. For all of them, remember these things. They are 99% of the time genetic. It's nobody's fault. It's not caused by anything. It's something they were born with. It moves the person towards dysfunction, in some cases not functioning at all. In other cases, they can get by, but they're functioning lower than they would if they got help. And for whatever area that their condition's in, they're going to have less choice. This is a critical understanding. So I had a teacher one time tell me that the student was very disobedient because he kept, she would say, stop talking, turn around. And when she would look 5 minutes later, he was talking with one of his classmates. And she defined that as defiance. Well, I did the assessment and found out the kid had a very severe case of ADHD. One of the symptoms of ADHD is being excessively talkative. They like to socialize. Not everyone has that, but oftentimes that's a symptom. And it was hard for the teacher to understand that the kid had less choice, right? That's why I gave you the analogy of, when women have their periods every month. If you think about it, you have less choice about how you feel and act and what you say and do. And it can cause problems, right? Well, when it comes to mental and emotional problems, wherever their disorder is, mood, thoughts, ADHD, controlling yourself, getting things done, or autism, social stuff, the person has less choice. Now, yes, if you held a gun to their head and told them to do things, a fair amount of them would be able to do it. Some would not be able to do it, even if you held a gun to their head. But it's a real thing. And unfortunately, when we do prison studies, about 60% of men and about 70% of inmates, excluding those with a gang background, we find that they have a condition in one of these 4 areas. So again, when you think of mental and emotional problems, think about our example with asthma. That's really what we need to do. We need to do the same things we would do for a kid with asthma or a person with asthma. All right, last kind of big thoughts here. So when I reflect on things in the Bible from beginning to end, from Genesis to Revelation, this word has been coming up for me a lot, and I think it applies to what we're talking about here. So obviously the Bible talks about, it says submit to God, and we would all nod, right? Yeah, we would submit to God. The Bible tells us to submit to every human authority, and that becomes a little more difficult. In Genesis, after Hagar has been wronged by Sarah and mistreated, and she runs away, God tells Hagar, go back to Sarah, the person who mistreated her, and submit to her. And then later in the New Testament, I believe it's in Ephesians, Paul says, submit to one another. So there's this theme, right, of giving in. And to me, what crisis and what mental illness has taught me, I feel like over the years, or maybe I'd like to think that maybe this is what God has taught me, is that, we're all inadequate. Something's wrong with us. Right? I mean, I'll ask people in a classroom, I'll ask them, raise your hand if you have a family history of medical conditions. And everybody's hand goes up. And then I ask people, raise your hand if you have a family history of mental and emotional problems. And maybe 1 or 2 hands will come up. And certainly from a spiritual point of view, we are inadequate. We cannot please God, right? We cannot get to heaven on our own. We cannot live holy lives. We need God. We also need other people. It's not God's plan for us to be an army of one. So to me, when I look at disability, when I look at mental and emotional illness, when I see bad things that happen to people, something that I feel like God's told me is that this is something to help us remember that we need God and that we need each other. Because there are some disabilities chronic disabilities where the people can never work and they need people to care for them. And I think maybe it's part of God's plan to remind us that, we need to, the body of Christ needs to rely on each other. And in that process, we have to rely on God, submit to God. We don't like any of it, but we kind of have to give in and let him take us where he wants us to go. All right. Well, I hope this has been helpful to you. I know we went a little bit over, but we covered two big topics today, and I hope that's helpful to you. Bye-bye.